delay, I would like to hand over the time back to Dr. Andrew Wong for today's topic on herpes zoster, severe cases, and latest updates on prevention. So, Dr. Wong.
Thank you very much, Dr. Ng, for your very kind introduction. And I'm really privileged today to share with you all about a topic which is concern of all of us, or even our family members, and which we see quite often. And then there are also some updates on vaccines as far as prevention goes. And so today I'm going to go through the disease burden and share with you some of the severe consequences of herpes zoster, and about some news on vaccines. So as we all know, herpes zoster is a painful disease. But those who have that in the past will know, how painful it is, and how much a person would like not to have another episode, if that he had the one already. So it's a unilateral disease. So there are really not so many skin disease which present as vesicles in adults when you come to think of it, and especially if it is unilateral, and this is a clue to the diagnosis. Of course, preceding the eruption of the vesicle, there can be pain or some discomfort or burning sensation. But the important thing about herpes zoster is the postherpetic neuralgia, which we all know can occur in up to 30% of the patients with herpes zoster. And of course, with other sites of involvement, including the ophthalmic branch of the trigeminal nerve, it can cause herpes zoster ophthalmicus, which can occur in up to 25% of the patients, and associated with ophthalmic complications, including vision loss in a rare case. Of course, other complications including bacterial superinfection, nerve palsies, etc. But I really have to thank the organizer for asking me to speak on this topic, because by reviewing all the literature, I know herpes zoster is more than that. So it can be quite severe. Associated with some very severe, but a lot common manifestations, which I will talk about later. And as we all know, it is the varicella zoster virus, which cause chickenpox, which cause herpes zoster. It lay latent in the sensory nerve ganglia after the primary infection, and so it is only after primary chickenpox infection that a person is susceptible to herpes zoster. So when we look at the seropreference, for example, of Hong Kong, if you look at the table at the bottom, we know for people above the age of 39, more than 95% of the population is already seropositive for the VZV IgG. That is, they have already been exposed to varicella virus sometimes in their life. That does not mean that they have herpes zoster eruption in the past, that some people may not have. I, for example, do not have the herpes zoster infection, the chickenpox infection primary. But when I test for the occupational health, my IgGs are already positive. Okay, so that means I am also susceptible to herpes zoster later on in my life, and it's so common. It's estimated that 1 in 3 people develop herpes zoster sometimes in their life. And when we look at the disease burden, this is the data from Hong Kong Hospital Authority. So the attendance is highest as expected among people above the age of 60, and is highest among the people above the age of 80. And complications can be quite common. It occurs in around 1/4 of the people. Around 13% of the people have a postherpetic neuralgia. And as expected, the effect of aging on herpes zoster is the most important factor for reactivation of the virus. So, the orange line shows the immunity after primary infection, which peaked after primary infection, and then with time it will wane, especially during old age, that will decline. And with sometimes there are some exposure to the virus in the environment, and that they will help to boost up the immunity, but they will they will decline with time. So apart from age, which is the most important factor, other factors including medical illness will also prone a person to herpes zoster. This includes HIV/AIDS, malignancy, many kinds of autoimmune disease, including SLE, and even depression is associated with herpes zoster. So, of course, the disease itself in those cases can diminish the immune response of the individuals, and so the treatment for those diseases, which can be immunosuppressant. So this lists the relative risks of different kind of conditions which are associated with zosters. Of course, the most immunosuppressant condition, including bone marrow transplant or solid organ transplant, HIV infection are among the most important ones. And this is a series from China, and it was found that recurrence rate of herpes zoster is around 16% there, and it's quite high. But in general, it was called that the recurrence rate is around 5% in for people who had herpes zoster before. So, as we all know, if we recognize or diagnose herpes zoster, we will prescribe antiviral. But the thing is, in my experience, many times the patient may think this is due to something else, and then they delay the treatment. Because of course we know if it has to be effective, antiviral has to be given within preferably 72 hours of the onset of rash to decrease the progression of the disease, and also to decrease the chance of having patient having postherpetic neuralgia in the after the recovery. Of course, for treatment of postherpetic neuralgia, there can be traditional analgesics, and also some of these other agents which will damp down the response of the nerves to the pain. And but really, there are people who suffer a long period of time, in terms of months after the herpes zoster. And it can also occur in young age as well. And just an illustration of a case I saw some time ago. And this is referred from a surgeon to me, and the patient presented with abdominal pain for 2 days, and seen a surgeon and thought that might be due to some abdominal condition, and actually was admitted to the hospital for upper and lower endoscopy. And after admission, he was found to have some rash on the abdomen, and it was. The patient thought it might be some sort of allergy. When I was called in, and then when I saw him, and then this is a picture, and the diagnosis is quite obvious that it is unilateral and involving the lower chest. And then he was started on antiviral. And then after a few days, and the rash become less, and then less pain. But still, this young man, he had pain after 1 to 2 months after recovery, despite the treatment. So you can see even young people can be involved. But this man actually, he told me his mother just passed away 1 week before the rash onset, and he's quite stressed at that time. So you understand some stress can also be associated with herpes zoster outbreak. And so in summary, age is the most important factor for occurrence of herpes zoster, and so are other immunosuppressant conditions. Now there are many patients nowadays with various types of treatment, for example, for cancers and also for other autoimmune diseases. So they are also prone. And the current treatment, they are effective if they are given early, and but it really have to depends on the recognition and also the patient's presentation when they will present. And in the following session, I will go to share some of these severe consequences of the herpes zoster. It's not only a skin disease as such. Actually, it can cause prone a patient to some ischemic events, including cerebrovascular disease and also myocardial infarction. And this is a meta-analysis of patients with herpes zoster. And it was found that the pooled data showing there is a 30% increase in chance of stroke after herpes zoster. And actually, the risk is highest for people with herpes zoster ophthalmicus involving the ophthalmic branch of the trigeminal nerve, and it increased almost 2 times. And how about for myocardial infarction? It's also increased around 18% compared to people who don't have herpes zoster before. And in general, it was found that the risk of ischemic stroke is increased rather than the hemorrhagic stroke. And the risk is highest at 1 to 3 months post herpes zoster, and that it gradually declines with time. And paradoxically, it was found that this was in the people who are under the age of 40, who are more associated with these cerebrovascular events. This is more than people in the 40s, 50s, and 60s, and etc. Maybe the older age group, they have also other risk factors, for example, the atherosclerosis. But in this younger age group, they are not have those factors, and so they are even more prone to these ischemic events. It was also found that the risk of stroke was greater in people without treatment than people who are treated with antivirals. And as I've talked about, the ophthalmic branch involvement is most associated with the stroke. And what are the possible mechanisms? It was postulated that because basically this virus is the only virus that has been proven to replicate in arteries, the artery walls, you know, and then they can cause inflammation in endothelium, and so lead to an arterial thrombosis. The other mechanism is that the virus can travel along the nerve fibers in the trigeminal ganglion and damage the vessel wall, and then they lead to aneurysm and hemorrhage, as I'll talk about in the later slides. And also, it's possible that people who have herpes zoster, they have postherpetic neuralgia, and then the pain prone them to some sort of depression. And then depression, of course, we know is associated with decrease in immune function. That may also trigger the stroke. But anyway, this is another meta-analysis which shows a similar increase in the risk of stroke. And but we have to bear in mind, not all people with both virological and pathological proven disease in the CNS have rash. Actually, in one series, around 37% of them, they develop the so-called VZV vasculopathy without a rash at all. Okay. So we cannot base on the absence of rash to exclude this possibility. So in terms of CNS involvement, of course, it can be in terms of vasculopathy, myelopathy, or even retinal necrosis or cerebellar infection. Of course, the most common one is the postherpetic neuralgia. But in some people, even the herpes itself, they don't have the skin symptoms. This is called herpes synherpetic. So, and this is a series of talking about the so-called vasculopathy associated with herpes zoster. Up to 40% of them, they don't have zoster. And then these kind of symptoms, they can have a delay. And then the average interval is around 4.1 months after the onset of the herpes zoster. And then that when you do the LP, sometimes there's no LP, no CSF phagocytosis, no abnormality in 1/3 of these people. And so the absence of CSF phagocytosis does not rule out the diagnosis of VZV vasculopathy. And also, it's common finding that they may have some focal narrowing or stenosis in the cerebral arteries. But again, this absence of which cannot exclude the diagnosis. And people found that the most consistent finding for VZV vasculopathy is evidence of ischemic lesions on the MRI or CT. And also, the patients tend to have CSF positive for the VZV IgG. And VZV PCR, as we talked about, is not always present. So in this series, it was found that the presence of VZV IgG in the CSF is present in 93%, whereas the VZV PCR is only in 1/3 of the patients. Okay. So we can only use negative result in both the VZV PCR and the antibody. If they are both negative, we can quite reliably exclude the diagnosis of VZV vasculopathy. And it was found that, sorry. So these are the angiographic findings, and these lesions tends to be at the junction between the gray and the white matters. And this is a quite interesting case from the New England Journal of Medicine many years ago, like in the 90s. And this is presentation is those of CNS vasculitis. And actually, the conclusion at that time, they cannot make, they cannot define the exact course. And it was quite interesting because later on, 1 year later, in another journal, they review the sort of specimen from the patients, and then it was found that the VZV was present in the vasculitis sample in both the central and peripheral nervous system of the patient. And so the diagnosis was the VZV vasculopathy. And again, it stressed that the herpes zoster rash is not required for this diagnosis. And what features would alert us to the possibility? You know, can be a headache of an focal change that were progressive in the absence of rash. And in the CSF, there can be increase in the red cell. And there can be involvement of brain structure supplied by the large and small arteries. And there can be productive viral infection in the cerebral arteries, but not in the brain. Of course, the entity encephalitis or meningitis have also been reported among VZV infection. And what are the major features of a VZV vasculopathy? It can be unifocal or multifocal, and it can cause deep-seated infection more common than superficial infection. And white matter is more commonly affected than gray matter. And as I've talked about, it's the junction between the gray and white matter which are most commonly affected because of involvement of both large or small arteries. And commonly both are affected. And the CSF can be normal in around 1/3 of the cases. And the detection of VZV IgG is superior to detection of DNA for diagnosis. And apart from the brain, it can cause spinal cord infection. It can also cause aneurysm and also SAH, cerebral hemorrhage, carotid dissection. There were reports, it was a very interesting report of children, even after primary infection, when they have some contact spots, they have carotid dissection as a result. And peripheral artery disease can also occur. And these kind of vasculopathy can happen even after primary infection or herpes zoster infection in both children and adults. And if you are interested, you are advised to read this Lancet Neurology. This journal is quite interesting, I think. And I think I've talked about when to suspect, but it's basically a form of vasculitis of the brain vessels. And if you suspect, you should send the CSF for the VZV IgG together with the DNA. And because if we confirm, the patient will need antiviral treatment, plus or minus steroid. And there are also other rare entity whereby herpes zoster is also associated, including central venous sinus thrombosis. This is a case report of a case happening few days after the herpes zoster in a patient, a young patient, actually, yeah, in a 20 years old patient. And also his antiphospholipid antibody was positive. And there's in this paper, if you're interested, you can read up around a dozen of other cases. They tend to have quite a good prognosis after the treatment with the anticoagulant as well. And this is another rare complication of herpes zoster is in form of the so-called segmental zoster paresis. And in this case report, this elderly man had weakness of his upper arm of 10 days after herpes zoster onset. And it was estimated that the preference is around 3 to 5% among these sort of patients. So if a patient presents with symptoms like that, we may have to inquire about the occurrence of herpes zoster before to help us to pinpoint to the diagnosis to avoid, excessive investigation. And this is another case series of so-called meningitis in immunocompetent hosts. And this is a 29 years old patient who present with the trigeminal branches Herpes Zoster, and he had proven meningitis in terms of clinically. Had the signs are positive for neck stiffness, and also the CSF finding is compatible with meningitis, and he was treated with acyclovir IV. And by the way, if just a reminder, if we put a patient on IV acyclovir or the antiviral, make sure the patient is well hydrated, because I have seen patients who have renal impairment as a result of the especially IV acyclovir. And this is another lady which I saw, whom I saw, and she has a chronic renal impairment, and she actually had a history of Herpes Zoster years ago. And this time she had another episode of Herpes Zoster. She was given acyclovir, but one day afterwards, she developed confusion and disorientation, and she used to be like alert and conscious. And so I have switched her to another class of antiviral called famciclovir, and the confusion subsided right away. And then she was like treated. But this lady again presented with quite prolonged Postherpetic Neuralgia, unfortunately. And secondary infection is quite common, and so we have to be aware. And this 85 years old gentleman who presented with Herpes Zoster and actually had a CA-MRSA infection of the face, okay, and including the auditory canal. And then he was treated with MRSA IV treatment, and followed by decolonization to make sure it's clear of the CA-MRSA, and his case was notified for CA-MRSA as well. Similar rash to that with a lot of clustering. And I won't talk about this lady because of the time, just to remind that the so-called Ramsay-Hunt syndrome can happen. Sometimes the rash can be very inconspicuous. For this lady, there's only one little vesicle inside the auditory canal, and when you look at it with the oroscope. And there were also other people who report the use of statin may have cause an increase in chance of Herpes Zoster, but the verdict is still not confirmed as to the causal relationship. And if there is, the chance is that the effect is only like mild, and that will not affect the use of statin, because of the high risk group. Statin will reduce their risk of myocardial infarction and so another cerebrovascular event. But there were people who suggest, in some of these high risk group, if they are put on statin, because after Herpes Zoster, people may have more chance of MI, right? But if we want to reduce the chance of statin reducing Herpes Zoster, some people may suggest these people who are put on statin to be vaccinated for Herpes Zoster. So in the remaining time, I'm going to go through some of these new vaccine developments. It used to be the only vaccine available in Hong Kong is the live vaccine on the right-hand side of the slide. It's called, the brand name is Zostervax. And then it is a live attenuated vaccine, which is to be given like subcutaneously for 1 dose. And now, since last year, in Hong Kong, there's also a launch of a recombinant vaccine. And this vaccine has been in use in the US and other Western countries for a few years already. And this is a recombinant vaccine based on antigen called glycoprotein E, and together with a adjuvant system, which is AS01B, which will help the vaccine to have a very sustained response over a long period of time. So it is to be given intramuscularly, and then it's 2 doses, 2 to 6 months apart. And the most important difference between the new vaccine and the old vaccine is, for the old vaccine, it is contraindicated in immunosuppressed patients. And for the old vaccine, the live vaccine, the efficacy is also much less, as you can see. For example, in people 50 or to 59, the efficacy is around 70%. And people above the age of 60 is it fall quite rapidly, the kind of efficacy. And also with time, this vaccine, after 4 to 8 years, and the protection is reduced to very low level. And as for the safety, it's also associated with some local side effects in terms of injection pain or swelling, like 60%, on systemic effect in around 1/4 of the patient. And whereas for the new vaccine, the recombinant vaccine, the efficacy is much higher. As you can see, across all age group, up even above the age of 80, you can see the efficacy is above 90. And how about people may think it is only these studies only done in the Western countries, in Caucasians? No, they have also include Asian cohort. And then, for example, even Hong Kong is belongs to one of the sub-cohort Asian, and the same efficacy of about 90% among the Asian cohort. And this vaccine is also effective in preventing postherpetic neuralgia, up to 90% or more. And also not only postherpetic neuralgia, but also other herpes zoster related complications. How about safety? In terms of local, yes, for some around 80% of the people, they may have experienced some pain, and around 40% have some redness or swelling, but they will subside in 3 days or less. And as for systemic reaction, around 40% of people will have some fatigue or neuralgia. Again, they will subside in 3 days or less. There's no increase in severe side effects, and they have provide quite good immunogenicity even 10 years after the vaccination. And there are now good follow-up data for these people who are on this trial. And so long-term, up to 8 years or more, they are good protection. And even in mathematical model of up to 20 years, they will sustain the protection. So this, in summary, this recombinant vaccine was more than 90% effective in all age groups above the age of 50. And they reduced the risk of postherpetic neuralgia and other complications associated with herpes zoster. And the majority of side effect is mild, moderate, and transient. And how about the overseas authority recommendations? For US, this vaccine is recommended for prevention of herpes zoster in people who are immunocompetent above the age of 50. But if you look on the CDC website, it's more for people above the age of 60. Actually, as I've shown you at the beginning of the talk, the people above the age of 60 are the more risk, you know. And then for people 50 to 60, they have to be, you know, like clinical consideration, you know. But this Shingrix, the recombinant vaccine, is the drug insert is for people above the age of 50. Okay, so how about for people who previously had the live vaccine? They are also recommended to have the recombinant vaccine, and it's the preferred vaccine for the prevention of herpes zoster. And for people who have history of herpes zoster, they can also receive the recombinant vaccine to prevent the relapse. And there are different recommendations when I try to check the overseas recommendation. The US CDC say they recommend after the acute stage of the disease is over, the patient may have the vaccination. But actually, after the herpes zoster outbreak, the patient will have a boost in the immunity. So in some overseas countries, recommendation like Canada, they may recommend the vaccination to be at around 12 months afterwards. Okay, so that we can exercise the clinical judgment as to when to vaccinate. How about for immunocompromised adults? Okay, the FDA actually last year in July, they have approved the Shingrix, the recombinant vaccine for immunosuppressed patients. And in October, the Advisory Committee on Immunization Practices of CDC have also unanimously approved the use of recombinant vaccine in immunocompromised patients above the age of 18. And these are based on various studies among these immunosuppressed groups, including blood disease patients, solid tumor patients, transplant patients, and HIV patients. And so we will await the final CDC publication on the recommendation as to which group, so as to inform our practice. But right now, for Hong Kong, the licensure is for patients who are immunocompetent, who are above the age of 50. We hope that with the US changing the recommendation and other European countries, and Hong Kong may also follow suit. And these are the recommendations of other countries. I won't go into details because of the time. How about for, this is a frequently asked question, so now I want to talk about this topic. How about for patients who did not report a history of varicella? There are two possibilities here. That's what people might have already have the IgG, as I've told you, even without the clinical rash. But for the US CDC, they do not recommend checking this IgG before the vaccination. It's more on the public health ground, because if everybody need to have the blood check, they may have a lot of they delay the use of this vaccine in the DD groups. But they have a course. If a person really does not have a history, you confirm, the IgG is negative. So this vaccine is not for them. They cannot prevent the herpes zoster in people who have not been exposed to varicella before. But if just for a population basis, there's no need to check for review. I mean, it's up to patient about the age of 50. You just give it, because after all, as I've told you, for example, in Hong Kong, in people above the age of 39, more than 95 or even 98% of the population has been exposed before. So about the recommendation to use with other vaccines, of course, for COVID vaccine, we know for all kind of other alternate other vaccine to be administered with COVID vaccine, it has to be spaced out in a duration of 14 days. This is, I think, it's mainly to avoid the confusion in case some kind of side effect happens. We don't know which one is which. But for example, in US CDC, they can be the COVID vaccine can be given with other vaccines without regard to timing, because I think it's more like public health crisis situation. Okay, so if possible, I would still recommend a patient to, for example, of course, I will ask them to have the COVID first, okay, because it's a priority, and then space it out, and then by 14 days at least, and then followed by the recombinant Herpes Zoster vaccine. So there was also a warning of occurrence of GBS in an FDA warning in March last year. It was found that there was like 6 excess case of GBS per million after the first dose. But we have to put this into context because, one, the background risk of GBS, for example, in US is around 86 per million to begin with. And then secondly, GBS can also occur after herpes zoster. It was found that it can occur up to 250 per million. So overall, the recommendation is that the risk, the benefit is still higher than the risk in the at-risk groups as far as vaccination for herpes zoster is concerned. And also other vaccine like flu vaccine, they can also be associated with GBS, like 1 to 2 excess case per million doses. So the take-home messages today would be like accumulated evidence demonstrate that the herpes zoster increase the risk of cerebrovascular events in the short and long terms, especially in younger patients. And we need to think of this possibility in patients with granulomatous or other CNS vasculitis. And then if we suspect that, we have to check the CSF for VZV, IgG, and DNA, the VZV. And given increase in proportion of the aging population and also the immunosuppressed patients, this sort of severe complications may also increase in the years to come. And recombinant herpes zoster vaccine is effective, safe, and prolonged protection for the at-risk groups. And if you are interested, you might have a look at this article which I wrote of this. I don't know whether it's published online now. It should be on the Society of Physicians website. I list out the 10 frequently asked questions, which might help you to answer your patients' questions when you encounter. I think many patients ask about these vaccines nowadays. And I try to compare the old and new one and also list out the evidence. And further research, of course, we know now for the group of so-called immunocompetent under 50, they are not under the recommendation. But how about as we talk about at the onset, there can be increase in stroke risk in these people as well, you know, and so should they be protected as well with this vaccination? And that has to be answered in the future research, you know, and also whether, for example, some kind of stroke we have to rule out, and then whether we need the antiviral treatment that we have to find out, you know, and also as I talk about for statin users, do they have to be like precautionarily vaccinated for herpes zoster? And that is another question that we have to find out. With that, I will end my talk here. And if you have further questions, which I cannot answer in the Q&A question, you are welcome to email me. I will try to answer you with the literature that I have on hand. Yeah, thank you very much.
Thanks very much, Dr. Wong. So, Dr. Wong remind us that herpes zoster infection still is not it's a severe disease that may causes a lot of complications, especially pain in patients. And also, it is a completely preventable disease. So, are there